Bueno, bienvenidos a la primera Masterclass de Oftalmocórdoba 2021. Primero quiero recordarles de que todo el congreso va a quedar grabado a partir de dentro de una semana. Vamos a tener todo el material en nuestro canal de YouTube, así que los invitamos a suscribirse para poder revivir el congreso. También quiero contarles que por cuarto año consecutivo tenemos a la revista Review Ophthalmology y Oftalmólogo al Día como comunicadores oficiales de Oftalmocórdoba. Ya estamos trabajando con ellos hace 4 años y bueno, quería mencionarlos y agradecerles por su profesionalismo con Oftalmocórdoba. Bueno, quiero presentar en la primer masterclass a los doctores Marianne Price y Francis Price que nos visitan desde Indianápolis. Los doctores Price, para mí es un gran orgullo que estén aquí con nosotros. Yo cuando comencé oftalmología era un fanático de ellos, he leído todos sus múltiples papers, todas sus técnicas quirúrgicas que son brillantes. Personalmente estoy muy alineado con todos sus pensamientos con respecto a la cirugía corneal. Pienso que son los cirujanos de córnea del mundo. Así que es un gran orgullo para mí tenerlos aquí y poder disfrutarlos en esta primer masterclass. Y así que bueno, bienvenidos Francis, bienvenido a Marianne. Ya pueden comenzar con su presentación. Muchas gracias por estar aquí con nosotros. Es un gran orgullo para nosotros. Los estamos viendo muy bien y pueden comenzar con su presentación cuando deseen. Ahí se los ve muy bien. Si quieren comenzar con su presentación, pueden hacerlo.
Just start talking.
Am I supposed to be presenting now? I'm not hearing anything.
Sí, se ve muy bien, Francis. Puedes comenzar. Quédate tranquilo que estás muy bien. You can go on.
Okay, thank you. I didn't have any sound. I couldn't hear you. So I've been asked to talk about advances in anterior lamellar surgery, and these are my financial disclosures. Let me see if I can get rid of it. There we go. And now what I'm going to talk about this morning is new advances to improve DALK. And for technology, it's femtosecond zigzag side cuts and intraoperative OCT. And then I'm going to finish up about the risk of rejection. At least when I started doing DALK, I thought you couldn't get rejections, and of course you can. Now, to be effective doing anterior lamellar keratoplasty, I think it's important that we know how to do a variety of different techniques. And the gold standard is Anwar's big bubble. And that's certainly the gold standard for visual acuity. But it's important that you know how to do a manual dissection. There are times when you can't get a big bubble, or you don't want to get a big bubble because the scarring includes decimes, or perhaps they had previous high drops. And so you have to know how to do an anterior lamellar using blades and peel techniques. Now, there's a big difference between what we do now and what we did 30 years ago. And 30 years ago, we were looking at using the Barricare microkeratome. There were difficulties getting a smooth cut all the way across the cornea. It was difficult to match up the diameters of the donor and the recipient. We were doing manual dissections, hand dissections. And it's somewhat similar to now with a variety of blades. You could do a deep dissection. Of course, Dr. Malbrand in Argentina really popularized that, and it's still a very helpful technique that I'll talk about. But the difficulty with using the peel techniques was difficulty determining your depth of dissection, and sometimes even difficulty getting the injection of air to get down deep enough. So what are the challenges when you do anterior lamellars? Well, determining your depth of dissection, maintaining a uniform depth without multiple dissection planes, matching up your donor and recipient because you can get distortion or wrinkling of the bed, edge mismatches, especially in keratoconus, this can be an issue with the thin recipient. You have to have a particle-free interface And you need to have an escape plan if you're planning to do a big bubble and it doesn't work. So let me talk about what I see as new technology. Some of you may or may not think these are new, and some may think they're just fun toys. But the femtosecond laser to do zigzag side cuts, I think, are a big improvement in doing these surgeries. And we have more accurate ways of getting a deep side cut incision, I think, than metal blades. And then intraoperative OCT is a huge game changer. We probably do 1 or 2 deep anterior lamellars in our practice each week. And the OCT has dramatically made our success rate with these better. And we use this to determine not only the depth of the dissection, but how uniform it is. And we can still use a slit beam in some cases to see the big bubble. So let's talk about evaluating the corneal depth of our incisions. So preoperatively, you want to choose the technique you're going to do. Are you going to use a manual method of your side cut or a zigzag? Intraoperatively, we like to set the incision depth based upon pachymetry that we do, that we also look back at our Pentacam or pachymetry maps with OCT to make sure everything looks right when we measure our depth. Because if we go through the cornea, then it's extremely hard to get a residual bed that doesn't have a double anterior chamber. We have air in the stroma to expand and indicate the stromal depth and when we make our cut downs. And you can also put air in the anterior chamber, as Dr. Mellis has proposed in the past, but we think that's a more difficult technique. So what are some keys to success with this surgery? Well, we typically do retrobulbar blocks, and we want a soft or normal eye, so we like to have a pressure device like the Honan balloon on the eye for about a half an hour before we do surgery after the block. We use pachymetry to make a 2/3 depth if we're doing a metal trephination. We'll do 80% depth if it's a femtosecond. We make our side cuts, then we inject air either to form a big bubble or to help determine the cut down depth. And you want to be able to do a smooth, even handed dissection and peel. Yeah, I may have gone backwards here. So this is a video that I'm going to show start to finish with a femtosecond. And this is with an intralace. We have it docked up here. And now we've started to cut, and the cut starts posteriorly. So you want to watch closely to make sure there's no bubbles in the anterior chamber. And so this is a zigzag incision. And I think this is really the preferred technique that we have. And with the intralace, you can actually mark these marks on the anterior surface to line up the donor and recipient. So here, this is a case of a scar. So we're going to actually debulk the anterior part of the cornea. We don't do this with keratoconus. But if you have a nice thick cornea, you can debulk it sometimes. And then we're going to do a big bubble. At least I think we are. And I'm, of course, showing a perfect case. And this is a big bubble. You can see the feathery edge out at the periphery. We're going to debulk here with a corneal dissector. And then we'll usually make a cut down. What I like to do first is inject some viscoelastic into the big bubble. And this is typically the way it looks. You can see it just drip into the air. We make a small cut, and then I'm going to use some Anwar scissors to make a incision in that. And then what I like to do is use a patent spatula, because very often the big bubble doesn't go all the way out to our incision. So with a lot of our anterior lamellars, we're doing 9mm grafts, but the big bubble typically only goes out to 7 or 8 millimeters, and we'll go all the way around with that patent spatula, actually pushing the dissection out farther. Now, you can't do that with the bubble formation because the bubble will pop when it reaches that annulus at the edge of Dua's layer, if Dua's layer is real. but you can dissect it out with a patent spatula or other blunt spatula. And so here we're going to remove the stroma. And of course, we have, as I said earlier, the gold standard, the big bubble. Now, I think probably we're going to take off decimase in the endothelium here on the donor, and then we're going to suture it in place. And I'd say probably 1/2 to 2/3 of my DALKs that I do are not big bubbles. And I really don't get too concerned if I can't get a big bubble, because I'm so happy with our peel techniques. So what's great about a zigzag incision? Well, as I said, you can do this lamellar cut and debulk it, but don't try that with keratoconus, because if you debulk a keratoconus eye that's very thin, then when you try to inject your air, it's going to pop through anteriorly. You can leave 70 to 80 microns in the bed, depending on how accurate your readings are with your pachymetry. And so with the interlace, these are the steps you can use. You locate the center, you mark it with gentian violet, like with a Sinskey hook. We'll mark a 7 millimeter diameter, do pachymetry, then we'll put the on. You can have a little crosshair in it, and then do what I showed earlier. Now, this is an older patient that we did a zigzag on. A lot of the keratoconus eyes, you don't get this appreciation, but you can see the zigzag incision in the cornea. And when you go down to 80 microns, 70 microns to decimase, it's a pretty deep dissection, and it gives you a good dissection plane to start with. But you can see it a little bit better in this older, stiffer cornea than a lot of the young people you do keratoconus on. This is how it looks post-operatively. You can see the zigzag incision. This is one where the sutures are out. But this is how it's helpful for a keratoconus eye. So here's a schematic of what happens when we have a normal donor and we're putting it in a thin keratoconus eye. They don't match, and so you have to undermine your edges to kind of push it down to get the anterior surface to match up. But with a zigzag incision, it's like a floating boat dock. And so these incisions can come together, and you can get a nice smooth anterior and posterior surface with the zigzag incision. So I think this is a big advantage in keratoconus eyes. Now, I'm going to switch now and talk about intraoperative OCT. And I think this is truly a game changer. There's at least 3 companies that offer intraoperative OCTs. I'm a consultant for Hog Strite, and I'm going to talk about what we do with theirs. And of course, since I'm their consultant, I think theirs is the best. And I'm going to explain why it actually is. And it provides real-time OCT images of the cornea, anterior chamber, and posterior chamber. Now, what's different with the Hog Strite is that the injection image in the oculars is good enough to operate with. I don't have to look at the monitor to see what's going on. We use it in all of our DMEK grafts, and we don't mark our DMEK tissue. We use it for graft orientation. We use it in DSEK to look at the space between the donor and the recipient. And in DALK, this is the huge game changer, residual bed thickness and uniformity of the bed. Now, this is the way that it looks. On the left, we have a picture that we took with an iPhone. The company's not been able to give us a picture. And what we see here is the injection image is on. We turn it on and off with a foot switch. And so up above, you see this purple line, and that's where the OCT image is being taken. And this is a DMEK graft. And you can see that 43-year-old donor is tightly curled. In the lower portion, you have the injection image. You see the cornea, the iris, and the donor in the anterior chambers. So this is why we don't mark our donors, is we can very quickly and easily see their orientation. Now, there's 2 other ways that you see the image from the OCT. In the upper right, we have the image that's on the monitor attached to the microscope. That's where we do the programming. And on the lower right, that's the wall monitor. And this is what you'll see in all the talks, like what I'm going to show you now. No one sees the injection image other than the surgeon. and that is injected in both of the oculars, and you can turn it on and off so you don't have the glare from it unless you are looking at what you need to specifically during the case. This is just a picture of the microscope showing where the monitor is that we do the programming. Now, I'm going to just give you a little bit about DMEK. I know this is anterior lamellars, but this is how it works with DMEK, and I use a trifold technique. So this is being injected into the eye, and we have the normal view that you see through the coaxial microscope, but on the right is the inset of the OCT image. This is like from the wall monitor. And if you look at that closely, and I don't know if you'll see this in the talk, I'm going to use my pointer, but I don't know if it shows up for you. You can see it's curled, and it's curled correctly. So if endothelium's on the outside, we know that it's right. And so the right side is uncurled from this trifold, and on the left side, the trifold has not opened up yet. And I'm just going to show a video of a DMEK that we're putting in. I use an AC maintainer. Once we get it to the far side of the eye, we're going to take that out so the anterior chamber is shallow, so we don't want that donor to come out. We did a combined cataract with this. This is a trifold, and you can watch as we start to deepen the AC how this uncurls. And if you are able to see on your screens the inset, once I get it to unfold, we'll be able to see that it's curled correctly. Now, once we've identified that, then we just put an air bubble in, and essentially the case is all done. This shows an extremely cloudy cornea where if you did any kind of mark or notch on the donor, you'd have no idea really where it was, but we can see it with the OCT. And once again, this is a trifold where the right side is unfolded. You can see that it's curled correctly with the arrow, and the left side is not unfolded yet. But this makes these surgeries much easier to do a trifold. So what about anterior lamellars? That's what I'm here to talk about. Well, let's look in the upper left picture. Look into the coaxial microscope. You can see we have a manual dissection. And, you know, you can't really tell too much about it, but look at the OCT image. And this is actually an old one, some of the earlier versions of their OCT. And you can see how terrible that dissection bed is. Look how thick it is on the right side. And on the left side, it's much thinner, but still it's irregular. That's going to give a terrible visual result. So what does this tell us? Well, we need to do a better dissection here, or else convert it to a PK. And so I would prefer to do a better dissection and get a more uniform dissection bed. Now, what I've shown in the lower right is what we do now. And this is once again a zigzag incision. I've marked the cornea with a marker I'm going to show you in a little bit that gives us a circular mark, either 8 or 9 millimeters in diameter, with radial marks going out from it. But what's important about this is to look at the inset in the lower right portion of the screen, see how thin that is. That's going to give us a result when we do a peel that is identical to a big bubble. And postoperatively, you can't tell the difference when we look at them at the slit lamp. So here's this picture shown again, just so you have a little bit better idea of that OCT image, and showing a very good representation of what's wrong with that dissection bed. So here are the steps that we do when we do our peel techniques now. So we have the air injection, and we've done the cut down in the upper left, but if you look at the OCT image, it's too thick. That is not going to, I mean, I can do a peel technique, it'll peel nicely, but the visual result will be lacking. It won't be good. In the upper right, we've done further dissection, and if you look at the OCT image, it's nice and thin. And then in the lower portion, you can see that as we peel it, we're getting a nice thin dissection all the way across. And what are the tips to do a peel? Well, grab one spot and don't grab it again anywhere else, but keep it in one spot. Learned that from Dr. Malbrand. And pull it all the way across. And if you have to do dissections on the side, like you very often have to do, especially if it's a 9mm, do that, but just keep pulling it all the way across and you'll get a great result. And this is what it looks like when you finish. And if you look at the inset here, we have a nice uniform bed that looks pretty much identical to a big bubble on the OCT. And this is the way big bubbles look. They're a little bit thicker than you would anticipate, but the OCT kind of augments that thickness. So what I'm going to do here is just show doing some cut downs. And so we aerate the cornea, and basically you're going to cut down until it becomes clear or almost clear. Once you get to the clear area, you want to stop, because the next stop's the anterior chamber, and that's going to turn it into a PK, which really you don't want to do. So because this is going to be out farther than the peel areas, we're going to do a dissection all the way around, or at least part of it like this, to where you can get the peel to start. We're going to check the OCT and make sure we're deep enough. And then once we do that, then we'll start to do the peel. And it's so cool to see the peel. It just comes apart like that. Now, if you haven't dissected enough in the periphery, you need to get those more attached areas in the periphery dissected to have that nice uniform dissection plane. But you can see how it just peels off. And that's really one of the fun things of surgery, is watching a peel technique. You can see the uniform bed as I pan across the cornea. We're checking the bed all the way across, and it's nice and uniform. That'll give us an excellent visual result. Now, this is a real interesting case. As we do more and more of these DALKs, they're going to end up having cataracts. And so this is a patient that's had a previous large diameter DALK. I've just finished the cataract. It's keratoconus eye, so I had to use sutures to close the keratome incision. And now I'm going to hydrate the stab incision. I want you to watch the central cornea very closely as I do this. See that little fluid wave you see there? So the question is, man, what do you do now? Didn't really look too bad. Well, without the OCT, you can't really tell how bad it is. So I want you to look at the OCT image, the inset. We'll see if we get a good picture here. Look at that. It's separated the bed, and we got a lot of fluid in there. And that's probably not real good for the endothelium if we let it stay that way. We have a huge double anterior chamber, but you don't appreciate that with the coaxial microscope. So what we need to do here is we need to drain that. And so you can either do drainage incisions, venting incisions like we used to do for DSEK. But here, because I looked at it with the OCT, I'm just going to make an opening in the incision right over the area where I did the hydration. And I'm going to start draining fluid out. I'm also going to have a stab incision through an area that in the upper right where the bubble did not extend to. And I'm going to intermittently fill up the anterior chamber with balanced salt solution to get the eye firm, and then drain it. And as I do that, you're going to see this area of detachment go away. And you really need intraoperative OCT to know for sure when you get that to drain. You can see as we're draining it here, you'll see that area of detachment just go away. And the next day when we saw him in clinic, he was perfect. No detachment at all, and basically had 20/20 vision. But this is something that is potentially a problem. I've had this happen on a number of eyes that I've done cataract surgery after large diameter DALKs. And so this is just in summary what we see with the OCT. We have the injection image. The line shows us where it is. The surgeon's really the only one that sees this injection image. and it lets us tell what's going on as we do our cases. But I think it's been a huge game changer. And so I'm going to just give you a few tips. I know everyone in Argentina, you're all really good at doing anterior lamellars, but if you don't mind, I'll tell you what I think some of the tips are. Don't debulk the anterior stroma and keratoconus eyes until you have a big bubble. That can make the anterior stroma too thin so that when you inject and try to get a big bubble, the air will pop through the stroma instead of popping off Decimes. Tip 2, remember the big bubble does not always go out all the way to the side cuts, especially if your trephination or your zigzag incision is larger than 8 millimeters. Use a patent spatula to gently extend a dissection out to the edge of your side cut, and that'll make it easier for you, less likely to break it. You can use a portable slit beam to see if you have a big bubble. I'm going to show a picture of that. Unfortunately, my video is not working for that. You may need to remove some anterior stroma to be able to see the big bubble. And if you get a reverse action reflection with the slit beam, like you do with the keratoconus with a retinoscope, then you know you have a big bubble. And I have no financial interest in this, but I'm going to show you a marker that I use that I think makes it easier. And this is made by Phaco. This is what the marker looks like. You get a round circle with these 8 radial marks going out, and it just helps you center your trephination and do everything else after that. Now, you can get more than one big bubble, and sometimes you have to watch closely to make sure it's not a type 2 bubble. So how do you tell the difference between the two? This shows a type 2 bubble that's basically just Decimes membrane like we do for DMEK, and you can see the bubble on the right side of the cornea. There's no feathery edge. Now, those are supposed to form in the periphery, but I've had a number form in the center, like this one. And if that happens, you need to convert to a peel technique or a manual dissection some other way, and not try to complete that, because it's possible but very difficult to excise the stroma without breaking that very thin layer of Decimes with a type 2 bubble. This is actually, if you look at this OCT, we have a type 1 and 2 bubble here. And once again, I'm not sure if you can see my pointer, but on the left side, you can see a little, very faint line. And that's actually a type 2 bubble that formed underneath a type 1 bubble. And if you look in the picture with all the bubbles in the center, you can tell on the left side there's not as many bubbles. And you need to watch for these things. And certainly when you see any of that form, you want to stop injecting more air. And this shows it here, the same picture of the OCT. You can see the typical big bubble residual bed. And then on the left, you see the very thin type 2 bubble. So, traditional teaching is type 2 bubbles only form in the periphery. And I'm here to tell you that they can form in the center as well. This is the handheld slit beam by Etalon. I have no financial interest in this. It's probably the least expensive medical ophthalmic device that you can purchase. You can use that for DMEK, as shown here, to tell which way the grafts are oriented. And you can use it for the big bubbles to get to cross action. And unfortunately, my video's not working for this. Now, for the rest of my talk, I want to talk about rejections with ALK. I started doing ALKs because I thought, oh, you can't get rejections. If we go back 20 years, 22 years ago, everyone thought that the only part of the cornea that was really important for rejection was the endothelium. And the rest of it really wasn't that important. We could see epithelial rejection lines, but really the biggest immunologic reaction was because of the endothelium. Well, we showed with our DMEK data that that wasn't the case. With DMEK, we had a tremendously lower rejection rate compared to PK, 20 times lower in the first 2 years for rejection episodes and 12 times lower than DSEK. So we realized that the endothelium was not the most important. Maybe it's just as important as the others, but it's not the most important. And the stroma is important. So that means that when we do DALKs, that we can get rejections. And this is a stromal rejection that happened in a patient where the stroma was beginning to get cloudy. And we recently had one where the entire cornea was cloudy. And you can see the vessels coming in from the recipient side. And so you want to give these people steroids. I think it might be more common if you leave the endothelium on your donor for a DALK, but I don't have any data for that. It's just a feeling that I have. And certainly you can get reactions to the sutures. You can treat this with Avastin injections as well, but I think steroids are really the most common way that we treat it. So a few years ago, we looked at a number of our anterior lamellar cases. And basically, we wanted to look at immunologic rejection episodes after DALK and look at risk factors. And we published this in Cornea. And so this was a retrospective study. We looked at 251 cases that we did in our practice. And we had follow-up ranging from 1 month to 94 months. And our mean outcome measure was, did they get a rejection episode, which is obviously a stromal rejection because you're not going to see endothelial rejection in a DALK. Here's another rejection case. You can see the vessels growing in. They're really inflamed, and you can see the stromal edema associated with that. Now, when we looked at this, our demographics are a little bit different than Argentina. I think you guys are probably like 95% Caucasian. We have a lot of different races here in the US. And we looked at recipient age and race. Well, sorry about that. And what we found was that for the younger African Americans, the blacks less than 46 years old, they had a 45% incidence of immunologic graft rejections. Everyone else in the study, the Asians, Caucasians, and the older African Americans, we had a 13% rejection episode. And at this time, I can tell you that we stopped all of our steroids at 2 months after surgery because we thought, oh, you really don't need them because it's an anterior lamellar. So one of the things we didn't expect is that we looked at the difference between tree-find incisions and the laser incisions with the zigzag incision. And much to our surprise, we found that there was actually fewer rejections with the lasers than there was with a tree-find. Now, we do charge to do the laser incisions. It's a cash payment, so there could have been some issues with that. But we looked at the cumulative probability of a rejection in the first year was 9% with a laser and 20% with a tree-find. And so we looked at it here. You can see the difference over time. It was significant. Now, we did this with a multivariate analysis because we thought, well, maybe a lot of the younger blacks just can't afford to have the zigzag incisions. But when we did multivariate analysis, both of these things still came out to be important. To be young and black was independent of whether they got a tree-find incision or a femtosecond zigzag incision. So these were the things we found. What was not significant, the recipient gender, whether they had keratoconus or an opacity, or whether they had a big bubble or a manual dissection. So none of those were significant. It was just what their race was, their age and race, and then whether they had a tree-find or a zigzag incision. So eliminating the risk of endothelial rejection is often cited as the reason to perform DALK over PK. The main factor driving our short-term steroid regimen was that, but our DALK rejection episode rate was 13% in the first year. Now, our previous study, as I said before, showed less donor stroma resulted in lower rejection rates. DMEK was less than DSEK, and DSEK was less than PK. So taken together, this suggests that the corneal stroma can induce immunologic graft rejection. And so we think that's important to know. So here's the zigzag. What? Yeah. And this is once again the zigzag incision. So what's the deal with this? So I think when we do these studies, the important thing is how do we change our behavior? So what did we do? Well, we began keeping our patients traditionally on steroids now since that study through 6 months. We taper them down, try to get them off at 6 months. For our African Americans, we spend a lot more time talking to them about the importance of follow-up using the drops, and we actually give them higher doses of topical steroids after these anterior lamellars and don't taper them for 3 or 4 months after surgery. So I think that when we do these studies, it's important to modify our behavior if we find something, especially that we don't expect, like we found in our study here. And so that's my talk. I'm open for questions.
Bueno, muy felicitaciones por su presentación, Dr. Price. ¿Me escucha? ¿Usted me está escuchando, Francis? ¿Me está escuchando? Bueno, estamos con un problemita de retorno. No sé si me escuchás, Dr. Price. Are you hearing me?
I can hear you, yes.
Okay, thank you. Okay, we have some questions. Thank you very much for your great presentation. We have 2 questions. Which is your best option for the indication for DALK and for Phaco, for femtosecond assisted lamellar keratoplasty versus deep anterior lamellar keratoplasty?
I'm sorry, I don't understand what the question is. What do I prefer?
Yes, what do you prefer, Phaco or DALK?
Oh.
You know, Bascom Homer, they did the shallow ones.
Yeah, let me just make sure I answer this correctly for you. I prefer, if I'm going to do an anterior lamellar, to do a deep anterior lamellar with the femtosecond laser. I like to use the zigzag incision if the patient can afford it. We charge extra for that. I think it's easier if you do a deep anterior lamellar, either with a peel technique or a big bubble, to get an excellent visual result. I think it's harder to get a uniform dissection plane if you use any other technique. Now, I've used the femtosecond lasers to do the lamellar portion across the cornea, and none of those give a good visual result. The reason is no matter which technique you use, you're either applanating the cornea and inducing folds in the posterior stroma that you cut across, giving you a bullseye appearance in the stromal dissection. Or if you have maybe one that doesn't applanate the cornea, the posterior cornea is so soft that it doesn't cut as smoothly. And so I haven't found a femtosecond that I like to use for the lamellar portion of the cut. We've also used microkeratomes in the past, and then used either a tree fine or a femtosecond to do the side cut. And I think that the microkeratomes always create some irregularity in the way they cut. They cut a little different in the center to the periphery and from one side to the other. And if you vary your speed, there's always some irregularities. So I prefer to do a deep anterior lamellar if I'm going to do a lamellar graft. I've quit doing the more superficial grafts. And did that answer your question?
Yes, perfect. With the OCT, with your intraoperatory OCT, you prefer to use the OCT in DMEK or in DALK?
Oh, I like to use it for both.
For both.
So
okay.
we do all of our own donor preps for DMEK. I actually showed the US eye banks how to do donor preps early on in DMEK, and I've never stopped doing my own. In the US, it's like an extra $1,000 charge to have the eye bank do it, which a lot of people do, but we have our own surgery center. And I also teach fellows, and I think it's important for them to know how to do donor preps and understand how the tissue works. So we do all of our own donor preps. And I use the OCT. All of our doctors here use that. We do not mark. We don't put any reference marks on our DMEK tissue. We don't do any of the notches like Friedrich Kruse has talked about, and we don't do the S's or F's. And then it's nice. You don't particularly need it to do DMEK, but I think the OCT for DALK is a huge, huge improvement. Like I said, we can get our peel techniques to be, you can't tell the difference between post-op, between a big bubble and a peel technique if you use the OCT to make sure you have a nice deep dissection. So for us, it's really essential if we're going to do DALK to have our OCTs working.
Okay, Dr. Price, thank you very much for your participation here in OFTALMOCORDOBA. It was a great pleasure for us to have you, and hope you can join us next year. Thank you very much.
Well, hopefully we can do it in person.
Okay.
Virtual meetings are less expensive, but it's always more fun to get to talk to people face to face.
Yes,
Thank you.
I think it's better. Thank you very much. Thank you very much. Bueno, continuamos con las cirugías en vivo. En 5 minutos vamos a estar comenzando desde el quirófano de OFTALMOCORDOBA. Vamos a estar comenzando con la cirugía del doctor Noé Rivero. Noé Rivero va a hacer una cirugía de catarata con lente Isopure, así que los esperamos en 5 minutos.